Welcome to the training session on dysphagia and swallowing safety. Objectives: to recognize signs that indicate that an individual is experiencing or may be at risk for swallowing difficulties. To understand responsibilities associated with caring for individuals with dysphagia or swallowing risks. To comprehend reporting and documentation responsibilities. To increase awareness of interventions and prescribed treatments that are implemented when an individual has dysphagia or an identified risk.
Swallowing, or deglutition, is the process by which food passes from the mouth to the stomach. This movement is controlled by the nervous system and involves both voluntary and involuntary muscle contractions. Before food is swallowed, it is mechanically broken down in the mouth by chewing or mastication. The salivary glands secrete the enzymes lingual lipase and salivary amylase. Salivary amylase begins the chemical breakdown of starch, carbohydrates, in the mouth. The water content of saliva helps bind particles together to form a bolus that can be swallowed. Swallowing occurs in 3 stages. The first is a voluntary phase called the buccal or oral transit phase. Here the tongue moves upwards and backwards against the hard and soft palates to push the bolus into the oropharynx. Next is the pharyngeal stage, in which involuntary movements push the bolus through the pharynx and into the esophagus. Movement of the bolus stimulates receptors in the oropharynx, which send impulses to the deglutition center in the medulla oblongata and the lower pons of the brainstem. The brain signals the soft palate and uvula to close off the nasopharynx, and the epiglottis to seal off the larynx. This prevents the bolus from entering the respiratory tract. The upper esophageal sphincter relaxes to allow the bolus to move into the esophagus and contracts to reduce backflow into the pharynx. In the final esophageal stage, the bolus is pushed onward by peristalsis, a progression of involuntary wave-like contractions of the circular and longitudinal smooth muscles of the esophagus. As the bolus approaches the end of the esophagus, the lower esophageal sphincter relaxes and the bolus moves into the stomach. So, in summary, food moves from the mouth, through the oropharynx and esophagus, and then into the stomach.
Dysphagia can be caused by aging, cerebral palsy, stroke, cancer, dementia, Parkinson's disease. Medications. Dysphagia is common in persons with developmental disabilities, especially as they age or increase the number of medications they take. Is common in persons who have other medical conditions that affect the way the muscles of their body work, such as cerebral palsy, CP. The onset of dysphagia can be rapid or slow, depending on the cause. A person may have a change in condition, depending on a specific disease or medication. If they get better or change meds, dysphagia symptoms may decrease or resolve. Dysphagia can be life-threatening because it can cause a person to choke or to aspirate. How is swallowing assessed? Bedside evaluation, a clinical assessment which includes medical history, description of the problem based on report by the individual and/or caregiver, observation, and clinical testing. Modified barium swallow, MBS, a video fluoroscopic exam and X-ray procedure, which visualizes all phases of swallowing using trials of varying food and liquid consistencies. Fiber optic endoscopic evaluation of swallowing, FEES, a fiber optic laryngoscope passes transnasally, through the nose, to view the hypopharynx, lower part of the throat, and assess the pharyngeal phase of the swallow. Aspiration. Entry of food or liquid into the airway, also known as going down the wrong pipe, can occur before, during, or after a swallow. May result in aspiration pneumonia, a leading cause of death in persons. Indications of aspiration: coughing during or after meals, wet gurgly sounding voice, excessive throat clearing associated with eating and/or drinking, audible/noisy breathing, eyes tearing, face reddening, unexplained weight loss. Coughing. Protective reflex that protects the airway from foreign materials such as food or liquid by clearing items out of the airway. Silent aspiration. Silent aspiration occurs when food or liquid enters the airway and the person does not cough. Silent aspiration cannot be assessed at bedside and an instrumental assessment may be indicated. Reflux. Stomach contents, food and stomach acid, flow upwards from the stomach into the esophagus and sometimes into the throat, pharynx. A person must be upright to eat, drink, and take oral meds. An individual with reflux should never lie flat. Optimum positioning during eating and drinking helps. Maintain good body alignment, upright at 90 degrees unless otherwise specified. Provide comfort. Inhibit abnormal reflex patterns. Improve respiration. Minimize reflux. Follow plan developed by PT or OT for individual. Choking. Food enters the airway and becomes lodged, completely blocking the airway. This is an emergency and requires immediate attention. Dysphagia versus swallowing risk factors. Dysphagia is a diagnosed condition that indicates the person has difficulty controlling the movement of substances during the swallowing process. A swallowing risk factor can be any issue that has the potential to result in a situation that affects the health and safety of a person as they swallow. Risk factors may include difficulty or absent chewing, missing teeth or edentulous poor-fitting dentures, impulsive rate of eating, gorging/stuffed mouth, pica, eating non-edible items, pocketing and/or food residues in the mouth or throat. Individuals who pocket food. People can have pocketing of food or medication in their mouth, stuck to their teeth, or plastered on the hard palate. This material can be aspirated or can promote the growth of bacteria in the mouth, which contributes to the development of gum disease. Small cuts in the gums can allow bacteria to enter the bloodstream and cause other significant health problems, heart disease, infections, etc. Risk factors continued. Behaviors: agitation, lethargy, inattention, distractibility, vocalization during meals, laughing, crying, screaming, etc. Risk factors interventions. Modified food and liquid consistencies. Dining guidelines to slow down rate of eating. Positioning guidelines. Dietary changes. Aspiration/reflux precautions. Use of adaptive equipment. Monitoring of medication effects. Behavioral programs that identify observation/supervision requirements. The International Dysphagia Diet Standardization Initiative is a new framework that provides a common terminology to describe food textures and drink thickness. The framework includes food and drink descriptors along with instructions for easy, reliable, and accessible methods to test different foods and drinks. The purpose is to standardize dysphagia diets to provide more accurate consistency recommendations across settings. At DDS, we will continue to use the DDS diet consistencies provided on the left side of the chart. Some new additions and modifications have been added to stay current with today's evidence-based research. As always, we as DDS remain committed to providing the best possible care for our individuals with dysphagia. The chart below provides simple equivalents. Please read the information related to DDS diet consistencies in this table. DDS whole, IDDSI7 regular. As served in a restaurant. Assistance may be needed with cutting. Whole easy to chew, IDDSI7 easy to chew. Foods that are soft/tender textures. No size restriction unless specified. No hard, tough, chewy, stringy, crunchy foods. Assistance may be needed with cutting, peeling, boning, depitting. Soft cut up, IDDSI6 soft and bite-sized. Food is cut by hand into half-inch pieces. Can be mashed/broken down with pressure from fork or spoon. Knife is not required to cut food. Chewing is required. DDS chopped. Food is cut by hand to pea size, 1/4 x 1/4 x 1/4 inch pieces. Food should also be moist. No finger foods. DDS ground, IDDSI5 minced and moist. Typically prepared in a grinder, select foods may be fork mashable, e.g., ripe banana. Food is soft, tender, and moist. Can be eaten with a fork or spoon. Biting is not required. Minimal chewing is required. DDS pureed, IDDSI4 puree. All foods are prepared to a smooth consistency by grinding and then pureeing. Usually eaten with a spoon. Does not require chewing. Hold shape on spoon. DDS liquefied pureed, IDDSI3 liquidized. Moderately thick, can be eaten with a spoon or drunk from a cup. Cannot be eaten with a fork. Needs some effort to drink through a wide diameter straw. High-risk choking foods. Bread. Peanut butter. Nuts. Steak, sausages, hot dogs. Pineapple. Raw carrots, apples. Hard candies, lollipops, gum, marshmallows. Popcorn. Dry biscuits, scones, cookies, cakes. Foods with skin/husks, e.g. peas, grapes, bran. Lettuce, spinach, green beans. Watermelon. Liquid consistencies. Thin liquids, IDDSI0, nectar thick liquids, IDDSI2 mildly thick. Honey thick liquids, IDDSI3 moderately thick. Pudding thick liquids, IDDSI4 extremely thick. Adaptive equipment. Adaptive equipment refers to special utensils that a person may use when eating. A special cup that controls/slows the rate or amount of fluid that goes into a person's mouth as they take a sip. Divided plates and dishes with plate guards or raised sides. Adaptive equipment. Dysphagia and medication administration. Individuals with dysphagia are more likely to have trouble swallowing medication and are also more likely to be subject to medication errors. When giving meds to an individual, make sure they are awake and alert. Make sure they are sitting upright. Use their specific adaptive feeding equipment, e.g., maroon spoon, nosy cup. Make sure medication has been fully swallowed, and their mouth is clear of residual food, medication, or liquid. Ensure the individual has adequate fluids available during medication administration.
The next step is the actual administration of the medication. And so here's where we have to work very closely with the nurses who are administering the meds, but also with the patients and the family members too. We might have some care-resistant behaviors that we have to address, and so we need to be careful about that. And we also have to be aware of this issue of covert administration. When you put medication in food and the patient perhaps has some cognitive impairment and doesn't necessarily realize there was medication in that food, that's considered covert administration. There may be some legal implications there that might be worth talking to the physician on the case about. Generally, we try to put some specific protocols into place for each patient, and again, include some flexibility. Patients are going to need more than one strategy for medication administration because what works with tablets may not work with capsules, what works with larger pills may not work with smaller pills. So we need to make sure we're providing patients with a number of different options within these med administration protocols. It's a good idea to have access to those medications that cannot be crushed so everybody knows which ones those are. And we need to be sure that we're addressing the dry mouth issues before it's time to take the pills. So perhaps some sips of water before it's time to swallow the pill so the mouth is a little wetter and the transit of the medication through the oral, pharyngeal, and esophageal cavities is going to be facilitated. Sometimes when patients really absolutely can't swallow medications, we have to make a decision. And when I say we, I mean the speech pathologist, the patient, the nurse, the physician together. We have to make a decision. Is it worth giving this medication at this point? What are the risks of not swallowing this medication efficiently, the risks of choking, the risk of aspirating this medication as compared to the benefits of the medication itself? Is it better that do we perhaps wait until the patient is more alert? Do we perhaps wait until we've done a full swallow eval to see exactly what's going on? And so sometimes we have to make that, the team has to kind of make that call. This may not be a medication we want to administer right now. As a general rule, one pill at a time and follow each medication with food, with liquid, and then take another pill. We want to make sure we're getting good transit through the esophagus and certainly good pharyngeal transit as well.
Oral hygiene and dysphagia. Individuals with dysphagia who are dependent for oral care are at greater risk of poor oral hygiene and health. They are at increased risk of inhaling food, liquids and saliva into the lungs, aspiration. Aspiration of harmful bacteria that develops in unclean mouths and on dry cracked lips can lead to aspiration pneumonia. Oral cleaning can stimulate the secretion of saliva and activate the swallowing and coughing reflexes. Toothbrushing. To reduce risk of aspiration pneumonia for individuals with dysphagia, oral care should be performed at least 2 times per day. Suggested products to use include a dry, small-headed soft-bristled toothbrush with a pea-sized amount of toothpaste. Low-foaming toothpastes such as Sensodyne, BioExtra, or Biotene, dry mouth toothpaste, are good choices. Toothbrush suggestions. Position toothbrush at the gum line. If gum tissue is bleeding when you are brushing, please brush those areas more thoroughly. Teeth need to be brushed regardless if the person eats by mouth. Oral care for individuals who are NPO. People who do not eat can have dried secretions in their mouth that contain bacteria. These secretions can be aspirated and can contribute to the development of aspiration pneumonia. Staff responsibilities. Follow prescribed food and liquid consistencies when preparing/giving individuals food and liquids. Remember, prescribed diet is different from prescribed consistency. Follow consistency requirements when administering medication as determined applicable/possible for person. Follow dining guidelines, including using adaptive equipment. Follow positioning guidelines. Everyone should eat/drink/take meds in an upright position unless instructed differently. Maintain identified supervision supports. Follow behavioral intervention. Observe for change that may be related to medication or change in condition. Provide good daily oral hygiene to reduce risk of aspiration pneumonia. Responding and reporting. Immediate response to choking. Follow CPR training. Call 911, individual needs to be seen. Notify nurse and contact others, SLP/OT. Ongoing reporting. Report observations or new risk factors identified. Keep nurse informed of changes, increased temp or other noted difficulties. Keep SLP/OT informed of changes. Complete required documentation. Swallowing Episode Report Form, SERF. Incident Report, 255, Individual Specific Documentation. SERF. To document specific observations about an individual's eating/swallowing abilities. To be completed and signed by the persons who made the observation. The document is then forwarded to the registered nurse, RN. The RN documents follow-up actions taken to ensure the individual's health and safety. Used to identify observations associated with dysphagia and swallowing risks. Required to be reported promptly. DDS Eating Safety Reminders. Dysphagia. Know if the individual has difficulty in swallowing because of muscular disorders, disease or injury, certain medications, anatomical abnormalities, and/or neurologic conditions. Swallowing risks. Know the potential for danger to an individual's health, which might include oral health concerns, maladaptive eating behaviors, rapid eating, gorging/stuffing, and pica. Make a difference. Address food risks in the individual's specific manner by using eating and positioning techniques, aspiration and/or reflux precautions, use of adaptive equipment. And be aware of prescribed food and liquid consistencies. Provide good, daily oral hygiene to reduce risk of aspiration pneumonia. Supervision is key. Increase supervision and observation during eating and drinking. Look for unsafe behaviors or eating techniques and follow up with nurse/healthcare provider. Thank you for watching the Dysphagia and Swallowing Safety Training. Please answer the questions for this training before moving on to the next training module.